Afternoon, everyone. A very warm welcome to all of you for this webinar series by Pune Obstetric Gynec Society, the cutting edge webinars. And we are very fortunate to launch the first program of this series of webinars. And to grace this occasion and to give us the blessings, we are very privileged to have highly and really deeply honored to have great personalities with us today. And we have with us our chief guest, Dr. Jaideep Tank, a very dynamic President Foxy, Dr. Rajendra Singh Pardesi, President AMOX, Dr. Kiran Kurtakoti, President-elect AMOX, and Dr. Amey Purandare, Senior Vice President AMOX. We have also with us two very eminent speakers, Dr. Meenu Agarwal, President POGS, and Dr. Milisha, Vice President Foxy, past Vice President Foxy. And this is a webinar in association with Thane OBGY Society and Solapur OBGY Society. And we would like to welcome President and Secretary of both the societies, Dr. Vivek and Dr. Senapati, Dr. Supriya Arwari, and Dr. Meena. I request Dr. Meenu Agarwal, President of Pune OBGY Society, to give a welcome speech before we take the blessings from our honored guests.
Thank you, Vaishali. This is, as Vaishali said, this is our first webinar by Pune Obstetrics and Gynecological Society, and we are associating with Solapur OBGY Society and Thane OBGY Society, very dynamic president and secretaries of both the societies, Dr. Supriya, Dr. Meena Gunjotikar, Dr. Jitendra, I'm sorry, Dr. One moment. Jay Narayan Senapati and Dr. Supriya. So we have both the president and secretaries of both the societies with us, and a lot of audience also coming from these two societies as well as from the national board, national platform. Very honored to have chief guest Dr. Jaideep Tank, very dynamic, always reachable, very approachable, and a thorough gentleman. So thank you very much for joining us and giving us the blessings for today. We also have Dr. Rajendra Singh Pardesi, sir, President AMOX with us. We have Dr. Kiran Kurtakoti, President-elect AMOX, and Dr. Amey Purandare, Senior Vice President AMOX. So very, again, Pardesi, sir, you are, like this is dawn of the a kingdom jaisa rehta hai. I feel that way when I talk to you. So I think that is what it effuses from your personality. Thank you very much. And Kiran, I think, yes, Kiran has joined. Thank you, Kiran. And thank you, Amey, for joining for this particular webinar to grace the occasion, to honor this occasion. Thank you very much.
Thank you, Dr. Meenu. May I request Dr. Jaideep Tank, President Foxy, to give us his blessings and wishes.
Thank you very much, Vaishali. It's always a pleasure and a privilege to be a part of any activity of the Pune Society. And I must thank Meenu, Vaishali, and Charu for organizing this webinar, along with the Thane and the Sholapur societies. I think, Meenu, it's a very nice, very crisp webinar. You have only 2 sessions, and both of them are on very relevant topics. And of course, you're speaking in one of ovulation induction, and my good friend Milind is speaking on optimization of labor and intrapartum care. And you have very eminent chairpersons, Dr. Vivek, Supriya, Dr. Senapati, and Dr. Meena. And it is always a pleasure and a privilege to share a platform with Pardesi sir, someone I have known for many years, someone I regard as a guide and a mentor. Thank you, sir, for being here. And my very dear friends, Kiran and Amey. I wish the webinar all the possible success, and I know that it will be very helpful to all those who attend. And thank you again, Meenu, Vaishali, and Charu for having me here. Thank you.
Thank you, sir. And it is indeed it's very special for Dr. Meenu and myself, because you have always been a well-wisher and you have guided us when we were chairpersons with you. And so it is especially very important that you be here today for the launch of our first series of webinars. Thank you so much. I would now like to
Also, for the delegates who have joined, many of them have attended the ultrasound training course under Imaging Science Committee and Foxy. And Dr. Jaideep Tank was instrumental in starting that course for us. So, thank you very much for that as well. Thank you.
Thank you, sir. I would now like to request Dr. Pardeshi, sir, to say a few words and give us his blessings.
Good afternoon, everybody. Respected Dr. Respected Chief Guest, Dr. Jaideep Tan, sir, our ever active, ever smiling, and hardcore Foxian. I think this is the biodata. And POS office bearers, Dr. Minu Agarwal, Dr. Vaishali Chavan, and Dr. Charulata Bapai, and other office bearers. First, I wish to congratulate Solapur Vijay Society, Thane Vijay Society, Dr. Senapati, Dr. Supriya, Dr. Vivek Virkar, Dr. Meena Gunjotikar, our people only. And with three ever smiling personalities of POJS, Dr. Minu Agarwal, Dr. Vaishali Chavan, and Dr. Bapai. See, they are always smiling. So, for organizing such an academic and practical webinar on ovulation induction and our labor and intrapartum care. And with the galaxy of speakers like Dr. Milin Shah, Dr. Menu, Dr. Chairpersons like Dr. Virkar, Dr. Supriya, Dr. Senapati, Dr. Meena Gunjatek, I think this is going to be a great event. The important in this, I wish every success to Dr. Minu Agarwal for her future endeavor in Foxy, in her Foxy election as Vice President Foxy. Wishing every success to this. Thank you so much for inviting me. Thank you.
Thank you, respected sir, for your kind words and for your blessings to us. And Dr. Binu and I remember all the encouragement and guidance you have given us during our entire journey before we became chairpersons and throughout for the Foxy tenure. So thank you very much.
I remember when I was I was just getting installed or not even the imaging science chairperson. Pardesi sir had told me in Mumbai that he's going to do a live ultrasound workshop. And then with that, he will involve the imaging science committee. And I was so impressed and so overtaken by his gesture. So thank you very much, sir, for this.
Thank you, sir. Now it's a proud privilege for me to welcome Dr. Kiran Kurtokotti. And we at Pune OBGYN Society are indeed very, very proud as he'll be shortly installed as AMOG's president. And he's been working tirelessly for AMOGs and we've been working with him too. So welcome, Dr. Kiran.
Yeah, thank you. Thank you. My regards to Dr. Jaideep Tank, my good friend, for the first webinar that Pune Society is hosting under the aegis of Dr. Jaideep. And my hello to Dr. Pardeshi sir, who has always groomed every one of us, not only Binu and Vaishali, but he has been instrumental in grooming practically everyone. And we really share a special bond with Dr. Pardeshi sir. Thank you so much. And my brother Ameya, so Amey is laughing. So my brother Amey and all others, Milind, it's really a pleasure to be on the same platform, sharing stage with you and Pune and Solapur societies, and along with Thane, all good colleagues, all good friends together on this first platform. So I think I would congratulate Meenu and Vaishali and everyone who are concerned with the organization of this webinar. And I wish them all the best. Thank you. And really, Vaishali, Charu, and Meenu, they are our pillars of POGS. They have been doing fabulous work. And I hope, wish, and pray that all of the entire amounts blesses the Pune Society just as it has blessed me. Thank you so much.
Thank you, Kiran. Thank you so much for the blessings, for the kind words, and for the wishes for us. Thank you very much.
Thank you, Dr. Kiran. Now, it's a proud privilege for me to welcome Dr. Ameya Purandare, Senior Vice President, AMOX, to give us his wishes and say of a very dynamic and young youngster of working for AMOX and Foxy. Yes, welcome, Dr. Ameya.
Ameya, you're muted.
Yeah. Thank you, Vaishali, for those kind words. It's indeed a pleasure to be associated with Pune OBGYN Society, and it's very difficult to say no for any webinar or any event of Pune OBGYN Society, because like Minu Madam says that, you are the Damad of Pune, so you have to be there. Special thanks to Dr. Jaideep Tang for starting off this this webinar through the AMOGS societies. AMOGS has always believed in integration of all societies, unity of all societies. I think Dr. Pardesi has been very instrumental in unifying the entire AMOGS and making it one big family. I think with such collaborative webinars, that philosophy of integration, of unity, will go in a long way to not only increase the unity amongst AMOGS members, but also provide a much larger base for various doctors to avail of these webinars and benefit their patients. Special thanks to Meenu ma'am, because I worked closely with her as joint secretary with in the Imaging Science Committee. She's always a very helpful and a very graceful woman, and is very hardworking and has done enormous work in the Imaging Science Committee. So congratulations, madam. Special mention to Vaishali, who I worked with in the Perinatology Committee. And she's always ensured, I'm her junior from college, and she's always ensured that she cooperates and she encourages me in all my endeavors. And last but not the least, Charu, whom I'm constantly picking her brains on the various activities of the breast committee. I think she is also a dynamo. All three of you have great futures in leadership, and I wish you all the best. Meenu ma'am, especially for you, we are all with you.
Thank you, Amey. I mean, it really feels so nice to see the friends standing with you. You and Pratik were rock solid with Vaishali and me, both of us, during our chairperson time. So thank you very, very much for this kind blessings and good words for us. Thank you.
Thank you, Dr. Ameya. And like Meenu Madam said, you were big support for us, especially, for every work that we did as chairpersons during that tenure. When you helped us even right up to the release of Oxyfocus, you have helped us, and we have unforgettable memories of that year working with you. So thank you very much. And with this, we come at the end of inauguration, and we would like to proceed with the scientific session. And thank you to our chief guests, Jaideep sir, and our guests of honors, Pardeshi sir, Dr. Kiran, Dr. Ameya. So with this now, we proceed to the further session. So since Dr. Milind Shah has requested to start with his talk first, I request Dr. Sandhya Mishra to take over and welcome sir to deliver his first talk.
Just before that, Charu, do you want to say 2 lines?
It is so sweet of you, Dr. Meenu. We are all the hosts, and we take great pleasure and pride in having such amazing chief guests and guests of honor for our, cutting edge webinar, which starts today. And indeed, very, very humbled and privileged to be associated with a president like you and a general secretary like Dr. Vaishali Chavan. So thank you, respected Dr. Jaideep Tang sir, Dr. Rajendra Pardesi sir, Dr. Kiran Kurtukoti, and of course, Dr. Ameya Purandare, for all the blessings for this wonderful webinar series that we have started. And we look forward to having you all as guests, as speakers, as the series progresses. Thank you very much. Thank you.
Thank you, Charu. Yes, Sandhya.
So good afternoon, everyone, all the respected dignitaries and the chairpersons. So with this, we begin with the first session. And to chair this session, I call upon Dr. Meena Gunjotikar, madam. She is a secretary, Solapur OBGY Society, and she's a practicing consultant since 18 years, and also an honorary consultant at SSNJ Ayurved Hospital. And with her, I would request Dr. Charulata Bapaya, our very own dear clinical secretary of POGS, to please chair the session along with her. Dr. Senapati sir, who is the president of Thane Obijbai Society, will be joining in a short while probably. So I request Meena madam and Charu madam to please chair the session and kindly introduce Milind sir.
Thank you so much for this opportunity to be here as chairpersons along with Dr. Meenal Gunjotikar. And indeed, such a proud privilege to introduce none other than Dr. Milind Shah sir. Dr. Milind Shah is a well-known personality in Foxy and to each and every one of us. I take a great pleasure and pride in saying that he is one of the chief advisors of the Study on Female Breast Committee, Foxy. Dr. Shah has always been a guiding light and he always gives us wonderful ideas and inspirations as to what new we can do for the breast committee. Dr. Shah and myself share another good bond in the form that many patients from Solapur keep coming to Pune and vice versa. And so I think we just delivered somebody he knows and he just delivered one of my patients. So it is a great give and take between Solapur and Pune. And coming to his academic achievements, he has been the vice president of Foxy in 2011. He's been the president IMA of Solapur branch 2021-22. He has chaired the Safe Motherhood Committee of IMA Maharashtra State, and he has held such numerous positions that it is he's indeed a phenomenal leader, and he's been the professor. He's the professor and HOD of in the Solapur Medical College. He runs his own hospital. He's attached to so many other hospitals. Sir, we really wonder how many hours you have in your day to fulfill so many activities. And over to you for your talk, and we are eager to listen to you, Dr. Shah.
Thank you very much, Charu. It was indeed a pleasure to be the first actually speaker for the first start of this cutting edge webinar of the Pune OBGYN Society. And I must say big thanks for such a kind words, but that's very true. The patients, they pass on the compliments about you always makes me more, very careful about the patients as well. And that's really a good practice what we think about. I must congratulate Pune OBGYN Society and all those stalwarts. They are all so close friends of mine. And we know you have started this wonderful, actually, the idea of having cutting edge webinars whereby all these common things we should definitely discuss with our colleagues as well. When I received a call from Dr. Vaishali other day, rather on Saturday, that whether you'll be able to speak on this topic, and I was very happy. I said, good, because this was my thesis topic. And that's why I practice that day and out. So I know everything about the active management of labor. And that was under the aegis of Dr. C.N. Punandre. So I thought, yes, I must definitely see that whatever I know I should share with you as a practicality as well. Congratulations to all those actually stalwarts here for being here and coming, like Dr. Jaideep, Dr. Rajendra Singh, Ameya, Kiran. All are so good friends and always been a sort of, the support for me for all my ventures. Of course, I must say thanks to all my two societies who are be here actually for this particular workshop of the CME, the Thane OBGYN Society and my own Solapur OBGYN Society, Dr. Senapati, Supriya. What I can say about her, she's very close family member of mine, Dr. Virkar and Dr. Meena Gunjotikar. So friends, it's pleasure definitely to speak something very different about this topic, and that will be definitely, I'm very sure you all will be having a lot of questions as well about that. I will just share my slides and let me see whether I can share that. Yeah.
We welcome Dr. Senapati for this particular session. He is the chairperson. So over to you, Dr.
Yes.
Senapati. You can kindly take over.
Yeah, good evening, everybody. I'm in a
See you again
meeting,
today.
so
We met on Sunday and good to see you again today over here virtually.
yeah, good evening, madam, to give me this opportunity to be a chairperson in this talk. I know Milinsa also from since long time, but the only thing I was in a meeting, I think there is not much of data, internet data is there. So I don't know whether, am I audible?
Yeah, you are audible, Dr. Senapati, very
audible?
much clear. Yes, you are very clear.
Okay. Okay. So sorry that I'm a bit late and there is not the data, the signal is not good. So sometimes I might go out of the air. So I know Milinsa personally, so he is is a giant of this subject. So you
what is the actually most joyful part of this motherhood, that every patient of mine nowadays, they do the reels and they put it on the Instagram, and they make it such a wonderful that always feel that now I should not call it as a childbirth. I should call it as a childbirth celebration. And that's why I always try to see that whatever analgesia, whatever actually the anesthesia I can offer to my patients, I must do that. And that's how actually the intrapartum care has to be. And that is what today's topic is, how active we can be to have this intrapartum care in very active way, to see that everything is good. Patient also feel happy, feel painless. And for obstetricians, it can be a daytime delivery as well, because that is another need of the every obstetrician also. So this concept rests on three pillars: the providing optimum pain relief, use of analgesic and antispasmodic. Because all said and done, here in our country, patients, they have little concern about the epidural anesthesia. For example, yesterday I delivered a doctor and she wanted the epidural anesthesia during her labor. But when it comes to the 3 centimeters, she said, "Oh, doctor, I'm just thinking over, because sometimes being a doctor, I think about some of the complications as well." We counsel her. We told, yes, definitely we know about it, but we take due care to avoid those. And she opted for epidural. But there is another option which we can offer to such patients where they have little, the anxiety towards epidural anesthesia, that, prick on the back and all those things. That is the concept of this active management of labor. And probably you all must be knowing that Dr. Dafdari was the one who actually put this particular idea long back in 1990 about active management of labor, and so many drugs kept on changing. For my thesis, I had utilized the protein, tramadol, and the compost protein as a protocol. But again, we realized there are so many other things which are there. Definitely, we can use in far effective way, and we can definitely achieve what we want to achieve. So ensuring the adequate uterine contractions for the active management of labor is very important, because all said and done, still now I feel that people are not much aware or concerned about the uterine actually actions which are in coordinate, and that one need to understand very, very clearly. I remember during my PG days, Dr. Sardesai, she's my PG teacher, she used to take a wonderful lecture on this uterine actually contractions, and especially in coordinate uterine contractions, how we can regularize just with giving one injection compost. And quite often we find that everything is getting regularized and patient are having the vaginal cord. So all that is possible only and only when you have a close clinical monitoring of the labor events, maintaining a partogram. Recently, I availed the Manyata initiative, and quite often we realize that people are observing all that need to be observed in the partogram, but they don't want to keep the partogram for a variety of reasons, for the staff scarcity, their awareness, and all those things. But I take this opportunity to tell you all that all those who are running nursing homes must opt for the Manyata Lakshya Manyata initiative, and the staff from the labor room will get definitely trained for this particular activity in far better way. We always say that sometimes our own children, when they're at home, they are not properly taught by the parents, but someone else can teach them far better. Similar is the story. They get attracted. Suppose someone comes and those Manyata initiative, all champions, they work a lot to see that the active management of labor is very well taught to all those staff members as well. This concept was advanced by the Irish school. In 1973, O'Driscoll and his colleagues reported on the advantage of active management of labor, resulting in shorter labors, improved obstetric outcome, and lower cesarean section rate. Now, it is definitely need of the hour, because we understood that we want to reduce the cesarean section rate for a variety of reasons, though we keep ourselves with the options criteria put in our nursing homes also. But whenever there is a program labor, there is definitely reduced infection. The mothers, they don't get exhausted. There is no question of dehydration or the disillusion. There is no ketosis.
And yes, the fetus also gets benefited. Less likely to have the fetal distress as well. And for that, we know our regular partogram, which is quite busy. But here we call it the nomogram, which is very simpler one. Even the paramedical actually nurses also can fill up this very effectively, and we can avail what we want to do. Now, there's a little change in this alert and the action line, because we realize that sometimes some patients behave slightly different. So we'll have to take comprehensively all that happens during labor of the mother and the baby, and we can become a little more lenient as well by 1 or 2 hours, and we see that some of the patients get benefited by that extra allowance and they can have a vaginal birth as well. The patient selection is very important. There's no identifiable or any medical or obstetric complication. Primigravida with singleton pregnancy with cephalic presentation with spontaneous onset of labor, gestational maturity of 37 to 41 weeks. The admission test, which is very important, need to be reactive. The active phase of labor with cervical dilation 4 centimeter or 50% EFS need to be there before we put up them with all those drugs which we want to give for the active management of labor. But the multi-pair also can get benefited a lot. Rather, the duration from that management ensuing and the delivery is so less that we get benefited on various actually aspects of the maternal and child health, and also our as obstetricians health as well. Presence of anesthesiologists, neonatologists is definitely necessary, but that is nowadays everywhere. I mean to say it is not necessary there. They should be present for the round the clock, but they should be available on call. We need to see that this has been informed to the patient adequately with good counseling, and we'll have to do it during the active phase of labor. Sometimes we don't think about this active management for the obvious reason: cases of antepartum hemorrhage, preeclampsia, diabetes, poly or the oligohydramnios, CPD malpresentation or the pre-labor rupture of membranes, because we know that there are so many other complications which may come in front of us while observing those particular patients as well. It always starts with the active phase of labor. The starting point is very important. Quite often I have seen, whenever I have advocated that to some of our students, they get little hurried. They want to start it when the patient is still in the latent stage, and they don't get the results what they're expecting. And that's why one need to be very strict about this, watching those 3 contractions per 10 minutes, how many seconds they're lasting, the dilatation, effacement. It should be engaged, and there should be no CPD. And patient may also have actually the adequate knowledge about everything. The medications actually is a combination of drugs. Those are used for the labor analgesia with antispasmodic drugs, which help cervical softening, yielding, and the dilatation. The advantage is it provides benefit of drug synergism, but at the same time restricting actually the drugs to minimal amount commensurate with achieving progressive labor. The same time safeguarding the mother and fetus against major actually side effects. So what we do normally that we start with intravenous fluid. We see that the pains are optimal and they get 3 to 4 contractions for 10 minutes. If necessary, looking at the contraction, we can think about adding 2 units of oxytocin to the drip. Sometimes we add 1 unit as well to start with, to understand how the body is responding to that. And then accordingly, we'll have to go with the further actually the modification. The rupture of membrane is very, very important, because I remember Dr. C.L. Zaveri, who was my actually boss when I was in Nanavati Hospital in 1987. That time he always used to say, whenever patient comes in labor, just rupture the bag and then go home, she will deliver automatically. Ignoring the exaggeration of that, but we know that it definitely makes a lot of change as far as the breaking of the lysosomes, how the PG synthetase they get activated, how the prostaglandin gets formed, and how the labor becomes progressive or starts when we do the rupture of the membranes. Then we'll have to think about giving some analgesia, where the fortwine and the compose, which is actually an equal amount, we dilute them in 10 ml, and then we give only 1/5 of the dose, because that dose is adequate enough to take care of that pain actually what patient gets. and then we'll have to start with the other things required. The use of oxytocin need to be properly taught to all our staff as well as the nurses also, because otherwise there is every probability they may get the more hyperactive contractions as well. Similar is the case while giving this fortmin and the compost as well. Now observe the progress of the labor by charting the maternal and fetal parameters and assess the progress of the labor on basis of cervical dilatation, descent, and document it periodically on this nomogram. When the patient is in advanced labor, the fetal head pressing down on the pelvis, patient starts complaining about severe pain or bearing down sensation, and when the cervix is almost near full dilated, then we'll have to think about giving the ketamine. Now look, this is another actually the thing which we can keep at our hold. For example, quite often we have noticed that even administrating that ketamine is not required. Rather, I don't practice that because I feel that there is more actually vigilance required, and whatever effect we want to achieve, we get without using ketamine as well, and we can get the adequate analgesia also. So that is very, very important, and accordingly we'll have to think about it. It is getting more popularity as it provides pain relief and the patient satisfaction. But always in the cases, there are certain issues related to the ketamine usage. And then we, on the following scale, which is commonly pain scale, what we observe in any other actually the studies, we see the level of analgesia. And these are the certain studies which I'm going to run very fast because I know people want to hear about the ovulation induction, which is again a very important topic by Minu as well. But the studies that tell you about the same thing, how actually we can go towards the vaginal delivery, how we can come down with the cesarean section rate, and the mean duration of the active phase of labor, dilatation, all that definitely gets benefited. That one need to think about. The cervical dilatation in active phase definitely more or the more fast as well. Quite often we have seen that the patients progress so fast that we also sometimes get amazed how actually the cervix got dilated so fast with medication. Duration of the stages of labor also gets benefited a lot, as you can see the difference here, and the pain relief score in the study group compared to the controls, you can find the major actually change as well. The side effects observed more in cases than in controls which are related to drugs. Now, we'll have to see that how actually it helps in all those phenomena in the labor. And one more thing which we always add for this dilatation part is the giving injection epidosine or the injection protein. Now, with that, we give injection tramadol to avoid ketamine because that helps a lot to get more control on that pain actually which patients gets, and avoiding all those side effects of the ketamine. So all that one need to individualize according to his or her expertise and his convenience, and then accordingly we can see how actually these drugs are helpful without getting the all those side effects. Rarely we see this nausea, vomiting, drowsiness, but which subsides after 12 hours, and the complication rate is definitely less. Now, this makes a major difference when we use the these cervical dilatation agents, where you can see definitely the duration of the first stage of labor definitely is lower. Duration of the second stage of labor is definitely lower. Third stage of labor is also definitely lower, where we can definitely observe the active management of third stage. The duration of labor is definitely less, layer, and rate of cervical dilatation is definitely higher as well, because we know that it helps a lot. Now, how actually we can use that? All of you, I'm very sure, must have used both these molecules as well. The definitely you must have used this valethamide bromide, a very commonly used cervical dilatation agents, but one has to be very careful to see that it works effectively, but definitely helps to shorten the stage of second stage of labor. The side effects are comparatively less if we are closely having the vigilance on the dilatation and the status of the patient. No actually statistical significance was found when adverse reactions were compared with age group 18 to 25, 26 to 35 years. Therefore, ADR reported were irrespective of the age of the patient, and no life-threatening or the severe form of ADR was seen with hyoscine or the valethamide during the cervical dilatation. Quite often, I have seen some of my colleagues, they use the repeated dosage as well, which I definitely don't use very regularly. But the single dose, when we give at the optimum time, makes a major difference as well. It has been observed the comparison of all these drugs need to be seen how actually it works. Now, again, as I told you, it depends on the patient to patient. You have to have that clinical acumen, which you need to use the as a molecule for the cervical dilatation. But some of the studies they say that how actually there are differences of the headache and the cervical tear, which were less in the valethamide bromide group compared to the rotavirine group. It shortens labor with substantial pain relief, significant amnesty of the painful events of labor, average blood loss was definitely less. The duration of all three stages are definitely less. Obstetric management is simplified and lowering the incidence of operative delivery. The neonatal morbidity was similar to the control group. Quite often, I remember Dr. Dattari used to say that sometimes the baby is pink but takes little more time to cry. But that also we never and never observe when we see those babies actually at the end of it. Because what is required is the correct timing of giving the Camposan 14, which we give actually when at the start of the labor, I mean to say when the active stage starts, and those effects which we think about of the depression in the baby are not absolutely seen. Little support of the neonatal recitation makes a major difference as well. So thank you very much, friends. I'm very sure there must be a lot of questions coming to your mind, and I will be very thankful to answer. Will be happy to answer all those questions. Once again, I must say big thanks to Pune OBGYN Society, especially Minu and entire team of viewers for this wonderful opportunity to speak on your own thesis. And definitely, it's a pleasure as well to speak about it. Yeah, thank you very much. Yeah.
Thank you, Mr. Milind Shah. Amazing, very nice presentation, very good practical take-home points. So I think people who have small nursing homes and people who are practicing obstetrics day in and they will be really benefited. They will get benefited from this lecture of yours. Vaishali, you want to say something? Dr. Vivek?
Yeah. Excellent talk. And I would
Vaishali.
ask the chairpersons to give the expert comments, Dr. Senapati and Dr. Meena.
Yeah, thank you, sir. Thank you very much. Those were the very good suggestions for intrapartum care, 3 pillars. You have elaborated very nicely. Many drugs used in our residency like Drotin, Epidocin, you used to have in many doses. And sir, it was a very useful lecture for preventing maternal and fetal morbidity and mortality, so that to prevent the stillbirths and all the morbidity of mother and fetus. Well, thank you very much, and thank you for giving me this opportunity for Pune OBGYN Society. Thank you very much.
Thank you, Meena. Yes, I think Dr. Senapati want to say something. You're muted, Dr. Senapati. Can you unmute yourself? Yeah.
Yeah. Now, can you listen me?
Yes, definitely.
Is it audible?
Definitely.
Okay.
Yeah, yes, sir.
Thank you, Dr. Milind, and thank you, Minu Madam, giving me this opportunity to chair this session. This is a very nice practical thing. Dr. Milind told the crux of the thing is the partogram. If you follow the partogram properly, either you do it as a gynecologist or you train your assistant or the staffs to plot the partogram so you can avoid many of the complications. That is the crux of labor. So partogram is the main thing everybody should follow. But nowadays nobody is following partogram. Now, patient sometimes wants to do seizure, we do seizure. Then fetal distress are many times not detected and landed up with the IUFD. Then it is very difficult to face the relative. So that is one. And there are many drugs which are coming in and we are using, nobody is nowadays not augmentation, acceleration, induction, things are now slowly it is just vanishing away. Because once when Milind must be agreed with that, when we are resident, if we are starting Pitocin with any patient to augment and accelerate the labor, we sit with the patient. Either the patient deliver vaginally or the patient goes to the further cesarean section. If there is a latent phase of labor and there is something change in the partogram, we go for the seizure, and the resident who monitor gets the seizure. So this is how we have learned in a hard way, but there are certain things we will have to take care. It is a nice lecturer, and it will definitely throw light to all the consultant who are attending in a small nursing home. Thank you all. There was also, only for the students here, there was a new publication where they are doing sonopartogram. That means they are doing ultrasound and seeing what is the descent of the head. So with ultrasound, they're actually measuring the BPD and the pelvic diameters and the basic descent of the head with partogram. So they are making sonopartogram, and there are studies to show that probably gives us might in future give us a better correlation with whether the patient will deliver vaginally or not. So yeah, this is an advancement, but that facilities should be there. We should be. I am in a metropolitan city. You are in a bigger city. The people who are in the interior, this will be really a difficult task. Normal partogram, if they will follow, it will be very helpful for all the gynecologists in the interior places. Right, sir. Right, sir. I agree with.
Can I just request the host to please allow me to start my video?
Okay.
Host has enabled my video, rather disabled my video. I don't think he likes my face.
Neo, can you just enable that? They want to see your, mimicry and dance as well. See.
So thank you very much.
Minu madam and Milind, please excuse me. I am having a meeting. So in between the meeting, I came and joined. So thank you for
nice of you,
everything.
Dr. Senapati. Great.
Yeah. Thank you. Thank you so much. Okay. Bye.
Yes, Supriya. Yeah.
Supriya, you want to show some video?
No, her own video. Her video was not seen.
Okay.
Okay, her own. No.
Her own, actually, her own picture was
No,
not
I
seen.
have started. Yes, I have got
Yes,
the idea.
Supriya, you can speak.
We can see you. We can
No, I just wanted to say thank you. Very nice.
Make it horizontal.
Superb
Horizontal
presentation.
karo phone.
Yeah.
So after the first session, now we move on to the second session. And for that, I welcome Dr. Vivek Virkar. He is the president, Solapur OBGYN Society, and he is a consultant at Virkar Maternity and Nursing Home Hospital at Solapur. He is the honorary treasurer at RCOG conference, and also he is the honorary secretary of SOGS in year 2008 and 2009. Also, I welcome Dr. Supriya Arwari. She is the consultant obstetrician gynecologist and fertility specialist at Supreme Hospital Bhiwandi, and she is the secretary of Thane OBGYN Society. She is the national coordinator of Foxy Adolescent Health Committee and also the past president of IMA Bhiwandi. She has to credit various awards, which includes most prestigious Anandibai Joshi Award for meritorious service by female doctors. So I welcome both of you, sir and madam, and I would like to request you to introduce Dr. Meenu Agarwal, madam, for her talk on ovulation induction, simplified protocols for everyone. Virkar sir, is Virkar sir reading or should I go ahead?
Am I audible? Am I
yes,
audible?
sir, now you're audible. Yeah.
Good afternoon, everyone. It is indeed great pleasure to introduce Meenu Madam for today's speech on ovulation induction, simplified protocol for everyone. Before that, I must thank Meenu Madam for visiting Solapur, for our infertility CME, for giving one of the excellent talk in a rainy season that is preferable in the July when there was a lot of rain. So thank you very much. So before in her introduction, she is the president of Pune OBGY Society. She is the chairperson. She was chairperson of Imaging Science Committee Foxy 2018 to 21. She is elected board member of International Society of Gynecological Endoscopy. She is the first author of 4 books, authorized many chapters, and over 12 publications in international journals. She is a bachelor in reproductive endoscopic surgery. She is the course director of endoscopy training course in uh, endoscopy in UAE. She's a many award winner, many awards to her credits. India's greatest leader, icon of health, inspiring gynecologist of India, and Foxy's award, that is Foxy Chair, champion of Foxy's award. So I request Dr. Minu Madam, please go ahead with your speech.
Thank you, Vivek sir. Thank you for this kind introduction. Thank you, Dr. Supriya. Nice to always see your smiling face. So, yes, so I shall be starting my talk on ovulation induction, and I hope my slides are visible. And so, my talk today is going to be on ovulation induction for everyone. So it is not going to be an IVF or ART talk, because all of us in the practice, we do see patients coming with infertility, and we do need to do their ovulation inductions, IUI, all the basic things before we have, if we have to refer the patient for IVF to another center. Before I start with this presentation, I will just talk a little about the basics. So, because if we know the basics of ultrasound, basics of induction, and what is the normal physiology, how the ovary produces an egg, it becomes easier for us then to understand and to manage the ovulation. Is a very complicated, very complex process, but it happens so smoothly that most of the women conceive naturally without any difficulty, because the ovulation in the body is happening. The whole complex process is taking shape in a natural organic way. Very important first to understand this particular graph. So these are the primordial follicles, which are then developed into primary, secondary, and then antral follicles. So these are the primary and secondary pre-antral follicles, which form the antral follicles. Now, every month, every cycle, there are antral follicles seen on both the sides, in both the ovaries. Now, suppose there are 5 antral follicles on each side, out of which one grows bigger. Okay, so that is a selected follicle. So that can be 1 or 2 selected follicles, out of which one follicle then becomes dominant, which may not be necessarily be the bigger one, bigger selected one. And this particular dominant follicle then keeps on growing, and it always remains dominant till it ovulates. So this is how. Why is this particular graph important for us? It is very important because we have to look at the dominant follicle. Once this dominant follicle is seen on ultrasound, that is the time this follicle is secreting its own FSH. Okay, so it is not dependent on the E2. So it is secreting its own E2. So there is no negative feedback on this follicle. All other follicles die out because of the negative feedback of high estrogen secreted by this follicle. So when you see, look at this particular diagram here. Now, here hypothalamus is secreting GnRH in a pulsatile fashion, which is acting on the pituitary. This pituitary is producing FSH. FSH is acting on the ovary. And when the FSH is acting on the ovary, these follicles are responsive to the FSH. And that is how this follicle starts growing. However, once this follicle starts growing, it produces estrogen. Once it is producing estrogen, it tells the hypothalamus, the pituitary, I don't need more FSH. So don't secrete, give me any more FSH. Because the FSH is not coming, the smaller follicles die out, But this bigger follicle, which is a selfish follicle, is producing its own FSH. And at some point of time, when it reaches a certain size, it gives a positive feedback for the LS surge, which again acts on the ovary, and then it starts secreting with progesterone. So this is how the HPO axis and the follicle development works. And from here, we will take forward how to induce the ovulation, when to add the estrogen, when to add the gonadotrophins, and how to manage an ovulation in patients. Now we normally in practice, we see three types of patients. One is hypo patients. Now hypo patients come very early. See, she may be 14 years, 15 years, 16 years. So what is her complaint? She comes with her mother that she has got she has not attained menarche. So that is the complaint. How do we manage it? We, of course, do the ultrasound. You will find normal, so small sized uterus, normal vagina, normal ovaries. You do her FSH-LH, and FSH-LH will be low. If the FSH-LH is low, what will happen? There will be no effect on the ovary. So no estrogen, no progesterone. So she will not get her cycles. So how do we treat these patients? These patients with just counseling. And after that, we put them on estrogen plus progesterone every cycle, or we can even give them birth control pills, explaining to them why we are using the pill, and she gets her cycles every month. No harm done till she gets married. And once she gets married, she will not respond to either clomiphene or letrozole, because there is no FSH or LH. That axis is not there. So we have to give her HMG low dose, and that will cause ovulation for her to have children. So I hope this is how the hypo patients are managed for induction of ovulation. Then we have normogonadotrophic, that means PCO patients, but they are anovulatory. They are WHO group 2. And then we have the third group, which are premature ovarian failure. FSH is high, AMH is low. These are the WHO group 3. The fourth group of patients, which most of us are using ovulation, fourth group of patient, that is normal ovulatory patients. Why are we inducing ovulation? Because we want to take them maybe for IUI. We want maybe more than one or two oocyte, two follicles to come, so that we increase the chances of a conception with IUI. So whenever the couple is coming, generally we do something called a one-stop shop. That means everything is done at the same time. We also send her for semen analysis. We do the ultrasound for the lady. If she's in the follicular phase, we can also do the tubal patency test. If she's on day 2 and any hormonal tests are required, we can do that. And if required, we can also do TSH, prolactin, AMH. So everything can be done in one sitting. So you kind of have an idea what is going to be the next step for the couple. Then we have ovulation induction for spontaneous conception, ovulation induction for IUI, and very, very important, ovulation induction for PCO patients. So one is that patient is not ovulating, so we are inducing the ovulation. Second is the patient is ovulating, but we want more than one follicle, so we are inducing the ovulation. And third is that the patient is going in for some IVF, then we are causing a controlled super ovulation for the patient. Most of the IUI patients and spontaneous conception, we are looking at one egg to get fertilized, but we may need 2 or 3 eggs just to get a better chances of one egg getting fertilized. So what all we can use clomiphene citrate, we can use letrozole, we can use HMG, or we can use a combination. First, let us come to letrozole. Letrozole is the first line treatment. For so many years, there have been kind of a debate, letrozole versus clomiphene citrate. Somehow, ESHRE and the major organizations were not letting clomiphene citrate go as the first line treatment. However, in the last 2 ESHREs, very clear guidelines that letrozole can be used as first-line treatment for ovulation induction, and we must rule out any other infertility factors like male factor or any fibroid or all those things we must rule out, and then start the patient on letrozole. How does the letrozole work? Now, we discussed in the initial first slide that if there is a negative feedback, increased estrogen will tell pituitary to stop secreting FSH, and reduced estrogen, if estrogen is low, then it will tell pituitary that you secrete more FSH. So what does our letrozole does? It is aromatase inhibitor, and that lowers the estradiol levels. Because it lowers the estradiol levels, it increases the FSH and LH. So that is how it works. Very basic, but I think the youngest colleagues, students who have joined, they should know this. Then we can use letrozole with HMG. Always whenever we are giving letrozole, we start from day 2. So we give it for 5 days. We do the ultrasound. If we want to add HMG, when to add HMG? Very, very important question. We saw the first slide. I don't want to go back again there. Once you see the dominant follicle, 13, 14 millimeters follicle, that is when you add the HMG. Okay, because if you add it earlier and there is no dominant follicle, then HMG will act on all the follicles, and it will act, all follicles will start growing, and then you will have a problem with multiple follicles on each side. Second, very easy method for the gynecologist is you start letrozole, say, from day 2. So day 2, 3, 4, 5, 6, you have given letrozole. Day 7, if you do the ultrasound, you will find a dominant follicle 13, 14 millimeters in size. Even randomly, if you want to give a low dose gonadotropin, day 7 seems to be the right day. That means you finish 5 days of letrozole, and then you can start with with HMG. However, it is always better if you have seen a dominant follicle on ultrasound and then you add HMG. Now, once we have added HMG, when to give the trigger? Now, if suppose I don't give the trigger, what will happen? There will be endogenous SCG, which will cause a trigger. So why do we need to give the trigger? We need to give the trigger only for timing the intercourse or timing of the IUI. So this again should be very clear that LS surge will come in a spontaneous cycle for the patient. Anyhow, the LS surge will come, but we give SCG so that we can time the intercourse time and also the IUI timings. So what happens if suppose the endometrium is very thin and you don't know when to add the estrogen? Again, once you see a follicle which is about 13, I would not say 12 to 14, I will say 14 to 16 of the follicle. That time, if we add estrogen, it will not cause a negative feedback because this follicle is secreting its own FSH. So it will act on the endometrium, and the side effect of a negative feedback will not be there. So that is how we add the estrogen. Now, what is the role of clomiphene citrate? Where do we use clomiphene citrate? I already said letrozole is the first line of therapy. So for me, if I have to use clomiphene citrate, I will use it in 2 circumstances, which is backed by the good data. One is in poor responders. So suppose you have a lady who's 38 years old and she wants to just try a spontaneous conception or wants to go for IUI. Her AMH is low. So that is the patient. Instead of going in for letrozole, I would prefer clomiphene citrate for her. And a lot of data to back it up. Also in these patients, suppose we are giving clomiphene citrate, but the lining is not so good. Similar way, similar logic, once you have a follicle size more than 14 millimeters in size, that is when I will add the estrogen, estradiol valerate to her, till I get a good 7 to 8 millimeters or 8 plus millimeters of endometrial thickness, follicular size is around 20 plus, that is when I can give the trigger, or I can even wait for a spontaneous endogenous LS surge. So if I have to choose between aromatase inhibitors, letrozole, anastrozole, or clomiphene citrate, there are many meta-analyses, RCTs, which are showing clear superiority of aromatase inhibitors as compared to clomiphene citrate to get better pregnancy rates and better take-home baby rate. Then a major challenge for us comes in the form of polycystic PCO patients. Okay, now what do the guidelines tell us? Now, this is again very, very important. All of us get girls who are 16 years old, 17 years old, 18 years old, and they say, the mothers say that she has got PCO because they have just done an ultrasound and they come with the ultrasound report. ASHRAE guidelines very clearly say that PCO should not be diagnosed with ultrasound in girls where gynecological age, that means age after menarche, is less than 18 years. So suppose she had a menarche at the age of 12. So till the age of 20 years, you should not diagnose PCO on ultrasound. I actually have kept it in my OPD, and many a times the mothers coming with their daughters with PCO, I actually show them that this is not the right thing. She does not have any other symptoms. Only two things we should see: if she has hyperandrogenism, if she has oligomenorrhea, this is enough to diagnose PCO, and we should not go by the ultrasound. At a later age, of course, when we are doing the ultrasound, a follicle number of more than 20 or the ovarian volume of more than 10 ml per centimeter cube, that will tell us that this is a PCO ovary. So, though that is important, that we must diagnose PCO in a right way. Whenever a patient of PCO comes, she's got maybe oligomenorrhea, she's got hyperandrogenism, or she has got PCO ovaries, any of the two. First thing, infertility, first thing we do is we start her on metformin. I think now the consensus is very, very clear that metformin can be given to both obese and lean PCO. So just start her with metformin. Don't give a pediatric dose of 500 OD. We must start with 500 milligram twice a day for them. Of course, also the options of adding inositol is there. Some people believe in it, some people don't believe in it. So that again is an option which is there. Now, PCO patients, how do we start in PCO patients? First, as I said, we can first start with letrozole. Okay, we give metformin and then we give letrozole. We monitor the ovulation. If she ovulates, excellent. If she does not ovulate, then we can go for the gonadotrophins. Clomiphene resistant patients, letrozole not responding, those patients can go for gonadotrophin in PCO patients for a monofollicular growth of the follicle. So what are the drugs which we are in use? We have HMG, we have FSH, we have highly purified FSH, we have HCG. These are the urinary products. So if I say 75 units of HMG, that means it is 75 units of FSH plus 75 units of LH. Then we have recombinant products. We have recombinant FSH, recombinant LH, recombinant HCG. Then, of course, we have agonist and antagonist. So this is the basket that we have of gonadotrophins. But we must understand why we are using urinary and why we are using recombinant. So where to use, is there any difference? Should we change from one to another if one is not working? So we can discuss all of that in the Q&A session if you have any questions on that. Then we have a chronic low-dose gonadotrophins in PCO patients. So how do we start it? You start with 37.5 every day. Give it for 5 days. After 5 days, we do the ultrasound. If we find a dominant follicle, a selected dominant follicle, we continue with the same dose. the story is over. Okay, till this follicle reaches 17, 18, 19, then we give a trigger and we plan the IUI. However, if in 5 days we don't see any growth, then we can make it 75. Again, give it for 5 days. After 5 days, we can do an ultrasound. We see a dominant follicle, then we continue with the same dose till we see a dominant follicle. So most of the patients of PCO will respond to 75. Sometimes you may add 75 plus 37. Again, after 5 days, you may have to incrementally increase. Okay, so then we have something like a sequential therapy where we give first letrozole, then we add HMG. No dominant follicle with clomiphene citrate or letrozole. If you see a dominant follicle, then you can straight away add 75. But if you don't see a dominant follicle, then you have to again start with 37.5 and incrementally increase. What is the idea? We think that we might reduce the dose of gonadotropin required, and we can cut down on the cost to the patient. So that is the idea behind it. But there are no publications to show that sequential therapy gives a better result in terms of pregnancy rates as compared to only gonadotropins. So this is how the ovulation is monitored. On day 2, you do a baseline scan, and then you look at the follicles. And as the follicles are growing, the smaller number of follicles are reducing, and then this will reach a LS surge. Now, if you get a report from your sonologist, or if you have done your own sonography, you see the LS surge on ultrasound, you do the urine test, LS surge is positive, then you must do the IUI earlier, 1 day earlier. So don't depend on SCG, because this patient already has got her endogenous LS surge. So if she's for timed intercourse or for IUI, it should be within 24 hours and not after 36 hours. So very good idea for people who are practicing infertility, basic infertility. Keep the LH kits. It comes as iSure kit in your clinics, and just tell her to do a urine test. And if the urine test is positive for LH, that means she is either about to ovulate, or she will ovulate in a day. So that is important point that we should keep in mind. So these are the signs of the ovulation. Many times patients come and say that, doctor, my follicle does not rupture. What do I do? When I go for IUI, the follicle does not rupture. So again, it is important to understand that the follicle rupture is not an event. It is a slow process. So initially, you will find a little bit shrinking of the follicle, then some free fluid in the pouch and around the uterus and around the ovary, and then there will be some echogenic areas in the follicle. So these are the ultrasound picture which will actually, so what you do is you do the IUI, call her again after 12 hours or 24 hours. 90% of the cases she will have ovulated. If not, that means this was not a good follicle to begin with. This may remain there as a cyst on the second day of the subsequent cycle, and then again in the subsequent cycle, before giving SCG, you do the E2 values. If your E2 is more than 150 picogram per ml, then you give the SCG. Otherwise, it is a nonsense, no use, bekar ka follicle, and then that is not going to give you any pregnancy. Sometimes we may see a large follicle. We are inducing ovulation, large follicle, 7 day, 7 day, 8. Again, this is a nuisance value follicle. You follow the follicle which is lying next to it, and that may become the dominant follicle. And this follicle, if you do the E2 values, if to put the color Doppler, you will find that this follicle does not have a good blood supply, and the E2 values are not matching. In some patients, you will find patients with PID, endometriosis, that there is no rupture, but there is an LS surge. That means the endometrium becomes secretory, the follicle becomes echogenic, LH is positive, LS surge is there, but there is no rupture. So what does it mean? It is a luteinized unruptured follicle, very commonly seen in patients with PID and endometriosis, as I said. So these are the patients who will get benefited with either a laparoscopy, a tissue lysis, Or if you want to still manage them medically, here we can add antagonist to suppress the LH, add gonadotrophins, and then give the SCG. So these patients do well. Unexplained infertility patients, ovulation cycles are regular, everything is good, but they are having luteinized unruptured follicle. Very, very good results with antagonist and gonadotrophins. So these are okay. So, and sometimes we may find the follicles are very less. Just 1 or 2 follicles on each side. Patient wants to conceive spontaneously or with IUI. So these are the patients where I would think, and which is again, as I said, backed by data, we go for clomiphene citrate. And if need be, add gonadotrophins. So this combination works well, provided you get a good endometrial thickness for these patients. How to measure the follicle? Always in 2 diameters and take the mean of the 2 diameters. Second should be intersecting the first measurement in the center, and you take a mean of the 2. So this is how, and I was, as my respected chairperson said, I was the imaging science chairperson. And my advocacy was every obstetrician and gynecologist should be able to do a good pelvic ultrasound. It helps for, especially for infertility patients. It is really, when you do your own scanning and your own fertility managements, you can make decisions much faster as compared to when the patient is bringing in the reports from outside. So thank you very much. And I am thankful to you for giving me this time of listening. And if you have any questions, we can take it forward from here. Thank you very much.
Thank you, madam, for your nice presentation.
Thank you so much, Dr. Meenu. It was really a wonderful presentation. Very short, sweet, and absolutely to the point. And ovulation induction के ऊपर से मुझे एक पोएम याद आई, मुर्गा मुर्गी की, क्योंकि अंडों की बात हो रही थी, इसके लिए मैं अर्ज कर रही हूँ कि मुर्गी बोली शर्मा के मुर्गा मेरा दीवाना, मुर्गी बोली शर्मा के मुर्गा मेरा दीवाना, बोले अंडा तू मत दे, बनिए के यहां से लाना, बोले अंडा तू मत दे, बनिए के यहां से लाना, मुर्गा बोला इतरा के मेरी मुर्गी को कोई समझाना, मुर्गा बोला इतरा के मेरी मुर्गी को कोई समझाना, 10 रुपए के चीज के लिए डार्लिंग अपना फिगर मत गवाना. तो ये अंडे का फंडा आपने बहुत क्लियर कर दिया. And really nice, very lovely presentation, very useful for all spectrum of gynecs, right from grassroots level gynec to those who are doing advanced fertility. So thank you very much. It was a real pleasure to join you here on your webinar. Thank you for giving the Thane Society the opportunity of getting attached with the POGS program. And thank you to Charu also. I can see her there. Charu and you, my scrubs are of the same color. So again, a big thank you also to all our dignitaries who had joined us at the beginning. Jaideep Tank, Dr. Pardesi sir, Kiran, Ameya. Thanks to Milind for again another wonderful discussion. My co-chairperson, Dr. Virkar sir. Thank you all of you. Thank you, Vaishali. Thanks to all of you.
Thank you. Thank you.
Vivek sir, you would like to say a few words?
Very nice presentation, and very she has explained everything about the HPO axis and everything, means how ovulation induction is to be done, what drugs to be used, metformin should be, when it should be started, and all the doubts are cleared. And it was really wonderful presentation as usual. So very nice. Thank you so much.
Thank you, sir. It was a fantastic talk, Dr.
Your this poem can be used for donor and patients.
Having you is always lights up wherever you go. So you are so spontaneous, so artistic. So thank you so much for being here with us. Thank you, Vivek sir. And I request Dr. Charu Bape, our clinical secretary POGS, to propose a vote of thanks.
Thank you so much, Dr. Vaishali. Indeed, a very, very, very big pleasure to have had our first episode of Cutting Edge today. And POGS is really blessed and honored to have the esteemed Dr. Jaideep Tang sir, President Foxy, as the chief guest for today's function. We were also blessed to have none other than Dr. Rajendra Singh Pardeshi sir, who is the current president AMOGS, Dr. Kiran Kurtakoti, who is the president-elect of AMOGS, and Dr. Ameya Purandare, who is second vice chairperson of AMOGS, as our esteemed guests of honor. Thank you so much, esteemed faculty, for for blessing this particular webinar. We are also grateful to have had Dr. Milind Shah, sir, past Vice President Foxy, as one of the esteemed speakers to talk on such an important topic as intrapartum care. And of course, our dear Dr. Meenu Agarwal gave a fantastic talk on ovulation induction. We had great chairpersons in the form of Dr. Virkar, Dr. Supriya, and the president of Thane OBGYN Society, Dr. Kunjo Tikar, who all were kind enough to spare their valuable time and be with us today for today's webinar. Once again, I take this opportunity to thank each and every one of you and extend a warm invitation to you all for our AMOGS conference, which is to be held on 16th, 17th, and 18th of February. And we look forward to meeting each and every one of you in the beautiful city of Pune. Please come and enjoy our hospitality at that time. And I'm sure Dr. Meenu, Dr. Vaishali, and myself will be there to welcome you, along with Dr. Kiran Kurtakoti, sir, and all the rest of the organizing chairpersons. Thank you once again. Looking forward to many more such sessions.
Thank you, and see you all very soon in AMOGS.
Absolutely. Thank you.
Bye. Bye.
Thank you to BSV
Bye.
for this
Take care.
webinar.
Yes, thank you to BSV. Yes.
BSP, they
And Dr.
organize,
Sandhya.
and Dr. Sandhya for doing the master of ceremony and always looking so pretty. Thank you.
Thank you.
And the entire team of BSV.
We can